Let's discuss high-yield concepts on hypertension for your internal medicine exam and USMLE Step 2 exam. Hypertension is a leading risk factor for death and disability in the United States, second only to smoking. Globally, it is also one of the primary contributors to cardiovascular-related mortality and morbidity. The 2017 ACC and AHA guidelines redefined the stages of hypertension. The guidelines categorize blood pressure into different stages. Normal blood pressure is defined as a systolic blood pressure of less than 120 or a diastolic of less than 80. Elevated blood pressure is defined as a systolic of 120 to 129 or a diastolic of less than 80. Hypertension stage 1 is defined as a systolic blood pressure between 130 and 139 or a diastolic blood pressure between 80 and 89, compared to hypertension stage 2 is defined as a systolic of 140 or greater or a diastolic of 90 or greater. For accurate clinical management, it is essential to calculate the average of repeat blood pressure measurements taken with proper technique. To ensure reliable readings, patients should avoid smoking, consuming caffeinated beverages, or exercising within 30 minutes prior to blood pressure checkup. It is important that a properly calibrated and validated blood pressure device should be measured for measuring blood pressure. During the initial visit, blood pressure should be measured in both the left arm and the right arm, and the arm with a high reading should be used for subsequent measurements. The patient should be seated comfortably in a chair for at least 3 to 5 minutes with their back supported, feet flat on the floor, legs uncrossed, and the arm bare and supported on a flat surface at heart level. The cuffs must be appropriate, ensuring that the cuff encircles at least 80% of the upper arm. Using a cuff that is too small can result in an artificially high reading, while a cuff that is too large can produce an artificially low reading. At least two measurements should be taken and averaged, with approximately 2 minutes between each. If the initial measurements differ by more than 5, the process should be repeated. Question: when it comes to measuring blood pressure, which method is better, manual or automated? The American Heart Association recommends a validated automated office blood pressure device as the preferred method for evaluating blood pressure in a clinical setting. The process involves taking three separate automated measurements, ideally when the patient is unattended, and averaging them to determine the final BP reading. Fully automated devices that utilize the oscillometric method are often favored in clinical practice because they can reduce human error. These devices are capable of taking multiple readings without requiring any observer, potentially offering more accurate blood pressure measurements than the traditional auscultation method. However, it is crucial to ensure that these devices are properly calibrated to maintain accuracy. What about ambulatory blood pressure monitoring? Well, ABPM with an electronic blood pressure measuring device is considered the gold standard for assessing blood pressure outside the clinical setting. It is a better predictor of cardiovascular outcomes such as left ventricular hypertrophy and cardiac death compared to office-based measurements. The AVPM device is worn continuously for 24 hours or more and is programmed to measure and record blood pressure every 15 to 60 minutes. Normal blood pressure values with ABPM are defined as a 24-hour average blood pressure of less than 115 over 75, a daytime average of less than 120 over 80, and a nighttime average of less than 100 over 65. ABPM provides important information that supplements office blood pressure measurements, particularly in evaluation of conditions such as suspected white coat hypertension, suspected mask hypertension, suspected episodic hypertension, those with apparent treatment-resistant hypertension, patients with hypotensive symptoms related to blood pressure medications, and patients with autonomic dysfunction. Home blood pressure monitoring allows patients to measure their blood pressure at home, typically using an electronic device as seen on the image. It serves an alternative for out-of-office blood pressure assessments when ambulatory blood pressure monitoring is either unavailable or not well tolerated. Observational studies indicate that average home systolic and diastolic BP readings can be more predictive of cardiovascular mortality than office measurements, although they are still less predictive than ABPM averages. The benefits of home BP monitoring includes its ease of access, lower cost, and of course, convenience. Additionally, it can encourage patients to adhere to lifestyle modifications and take their blood pressure medications consistently. However, unlike ABPM, which provides continuous data through waking, sleeping, and activity periods, home BP monitoring only captures readings during waking hours and when the patient is at rest. When considering a home blood pressure machine, which one is better, an upper arm or a wrist BP monitoring? An upper arm cuffs are recommended over devices that measure blood pressure at the wrist or finger, as distal measurements tend to show higher systolic and lower diastolic values, which are less reliable. Patients should be educated on proper blood pressure measurement techniques, the ideal frequency and timing for taking readings, and the importance of not adjusting their antihypertensive medications based solely on home BP readings. It is important for patients to keep a log of their BP readings along with the times they were taken. Bring this log to the office visits to assist with ongoing management. Additionally, the blood pressure device should be brought to the office initially and at regular intervals to ensure the frequency of its readings. The USPSTF advises screening for hypertension in adults age 18 and older to identify those at higher risk of cardiovascular disease due to elevated blood pressure, allowing for early intervention to reduce this risk. For adults age 18 to 39 with a blood pressure below 130 over 85 and without cardiovascular risk factors, rescreening is recommended every 3 to 5 years. The USPSTF suggests annual hypertension screening for those at increased risk. Additionally, the ACC AHA recommends that adults with elevated blood pressure or stage 1 hypertension who are not yet on treatment have their blood pressure rechecked within 3 to 6 months. Once we start thinking about screening patients, let's define hypertension. Hypertension is defined as a blood pressure of more than 130 over 80 and should be diagnosed based on the average of two or more elevated systolic and or diastolic readings taken at least two separate occasions. To confirm the diagnosis, out-of-office measurements using ABPM or home BP monitoring are recommended. Multiple measurements over time offer a higher positive predictive value for diagnosing hypertension compared to relying on a single reading. Given the prevalence of white coat hypertension, it is recommended to confirm elevated BP with a 24-hour ABPM or a home monitoring before starting any blood pressure management. When evaluating a patient with a newly diagnosed hypertension, several critical factors should be assessed. It is important to gather a personal history, including any history of stroke, myocardial infarction, thyroid disease, kidney disease, obstructive sleep apnea, and other cardiovascular risk factors. Family history should be examined to identify any genetic patterns of hypertension or premature cardiovascular disease. Additionally, secondary causes of hypertension, which may be reversible, and modifiable factors contributing to elevated blood pressure should also be identified. It is crucial to assess for signs of end organ damage. Initial testing for newly diagnosed hypertension should focus on identifying common secondary causes, assessing cardiovascular risk factors, and detecting end organ damage. Lab work includes CBC, serum creatinine, estimated GFR, serum sodium, potassium, calcium, bicarbonate, fasting glucose, a lipid panel, and a TSH. Perform a microscopic urinalysis. Additionally, order a urine albumin and a urine creatinine to obtain a urine albumin creatinine ratio for patients with diabetes or those with a high suspicion of underlying CKD, especially if there's a positive family history or signs of end organ damage, such as left ventricular hypertrophy that can be found on an EKG. EKG should be performed to evaluate for left ventricular hypertrophy, a key indicator of end organ damage, or to detect a previous myocardial infarction. While not routinely recommended, an echocardiogram is necessary if the EKG shows evidence of left ventricular hypertrophy or in cases of suspected white coat hypertension. In these situations, the presence of left ventricular hypertrophy should justify antihypertensive medication, even if their blood pressure readings are within normal range. Here's a 52-year-old female presents to her primary care physician's office for a follow-up. She has a history of anxiety and mild hyperlipidemia managed with lifestyle modifications. During her last 3 visits to the clinic, her blood pressure readings were consistently elevated, averaging around 145/85. She is concerned about being diagnosed with hypertension, but notes that her blood pressure readings at home taken with a home monitoring device are consistently around 120/75. She denies any symptoms such as headaches, chest pain, or dizziness. Given this information, what is the most likely diagnosis? The correct answer is white coat hypertension. White coat hypertension occurs when blood pressure readings are elevated in a clinical setting but normal at home. For patients with a systolic blood pressure between 130 and 160 or diastolic blood pressure between 80 and 100, it is recommended to use ambulatory blood pressure monitoring or home BP monitoring to screen for white coat hypertension. Before confirming a diagnosis of white coat hypertension, it is important to verify the accuracy of out-of-office blood pressure measurements. This can be done by calibrating the patient's home blood pressure monitor against the office BP machine, or ideally by using an ambulatory blood pressure monitoring. While patients with white coat hypertension may have a slightly increased cardiovascular risk compared to those with normal blood pressure, the risk is still lower than that of patients with MASH or sustained hypertension. The effectiveness of antihypertensive medication in reducing cardiovascular risk for white coat hypertension remains uncertain. Nonetheless, lifestyle modifications are still strongly recommended. There is a 1% to 5% annual risk that white coat hypertension may progress to sustained hypertension. As a result, annual follow-up with an ABPM or a home BP monitoring is advised to detect any progression which might require the start of hypertensive treatment. In some instances, screening with echocardiography may be appropriate to assess for left ventricular hypertrophy in patients with white coat hypertension. If left ventricular hypertrophy is present, blood pressure management should be considered. Here's a 48-year-old man visits his primary care physician for a routine checkup. He has no significant medical history and he's not taking any medications. During the visit, his blood pressure is measured at 128/78. He mentions that he feels fine and denies any symptoms such as chest pain, shortness of breath, or headaches. However, at a recent health screening at work, his blood pressure measured was 138/84. The patient states that he is often stressed at work and wonders if this could be affecting his blood pressure. What is the most likely diagnosis? The patient likely has mask hypertension. Mask hypertension occurs when a patient's blood pressure readings are normal in the clinic but high outside of the clinic, like a patient's home. This condition is associated with a higher prevalence of end organ damage and an increased risk of cardiovascular disease, stroke, and mortality compared to patients with normal blood pressure and white coat hypertension. For adults with elevated office blood pressure who do not meet the criteria for hypertension but exhibit signs of end organ damage such as left ventricular hypertrophy, it is recommended to screen for mask hypertension using daytime ambulatory blood pressure monitoring or home BP monitoring. In suspected cases, a 3-month trial of lifestyle modification is recommended. If the daytime ABPM or home BP readings remains at or above 130/80 after this period, the initiation of antihypertensive treatment should be considered in this patient. Fill in the blank. A patient is considered to have blank when they are on optimally tolerated doses of 3 first-line antihypertensive agents but still have a blood pressure above the target goal. What is the correct answer? The correct answer is resistant hypertension. Resistant hypertension is defined as blood pressure that remains above the target goal despite the use of 3 antihypertensive agents from different classes, one of which must be a diuretic. Or the second definition is resistant hypertension is defined if the blood pressure is controlled but is on 4 or more medications. But of course, before diagnosing someone with resistant hypertension, it is important to ensure that the patient is accurately measuring their blood pressure, adhering to their medication regimen, and that any secondary or reversible causes of hypertension are being addressed. In clinical setting, we're always checking for pseudo-resistant hypertension. Pseudo-resistant hypertension refers to the appearance of resistant hypertension but is actually due to factors such as medication non-adherence, white coat effect, inaccurate blood pressure measurement, or undertreatment. To accurately diagnose resistant hypertension, it is important to ensure proper blood pressure measurement. Blood pressure should be calculated as the average of 3 readings taken with the automated device after the patient has rested for 5 minutes, with their feet flat on the floor, back supported, and bare arm supported at heart level. It is a fact that non-adherence is a frequent cause of pseudo-resistant hypertension and is more common than often anticipated. If a clinical vignette indicates resistant hypertension, it is important to assess for secondary causes of hypertension. Patients with resistant hypertension should be evaluated for secondary hypertension since recognition and directed therapy may improve blood pressure control. One example is obstructive sleep apnea. OSA is a common in patients with resistant hypertension. The proposed mechanism by which OSA may contribute to or exacerbate hypertension include increased upper airway resistance, hypoxia, and hypercapnia. These factors lead to endothelial dysfunction, inflammation, oxidative stress, and increased activity of the sympathetic nervous system and the RAS system, ultimately resulting in increased vascular tone and elevated blood pressure. Given the high prevalence of OSA in patients with resistant hypertension, routine screening for this condition is advisable in this population. Tools like the Stop Bang questionnaire can help identify patients at higher risk who may benefit from further testing with polysomnography, which is the gold standard for diagnosing OSA. The Stop Bang score includes 8 factors: snoring, daytime tiredness or sleepiness, observed apneas, high blood pressure, BMI greater than 35, age over 50, neck circumference of at least 17 inches in men, or at least 16 inches in women and male gender. A score of 4 or more suggests a high risk of OSA that would warrant ordering a polysomnography. Treating OSA with continuous positive airway pressure, also called CPAP, in patients with resistant hypertension has been shown to lower 24-hour ambulatory blood pressure. The more consistently patients use CPAP each night, the greater the impact on their blood pressure. Hypertension is both a cause and a result of chronic kidney disease, making it prevalent in this patient population. The mechanisms proposed for hypertension in kidney disease includes an overactive renin-angiotensin-aldosterone system, increased salt and fluid retention, endothelial dysfunction, and a heightened sympathetic nervous system activity. In patients with elevated serum creatinine or abnormal urinalysis, CKD should be evaluated and recognized as a potential risk factor for resistant hypertension. Primary aldosteronism is characterized by the autonomous overproduction of aldosterone, leading to salt and water retention, renal potassium wasting, and subsequent hypertension and cardiovascular disease. This condition is more prevalent than previously recognized, with an estimated prevalence of 8% to 30% in various hypertensive populations, and is often goes undiagnosed. Notably, hypokalemia due to renal potassium wasting is observed in only 9% to 37% in patients with primary hyperaldosteronism, contributing to the underdiagnosis of this condition. The plasma aldosterone to renin ratio, in short ARR, is the most commonly used screening test for primary aldosteronism. Treatment for primary aldosteronism includes surgery in cases where a unilateral aldosterone-secreting adenoma is identified, in patients with bilateral adrenal disease, or for patients who are not a surgical candidate, treatment with a mineralocorticoid receptor antagonist such as spironolactone or eplerenone is recommended. Renovascular hypertension is a condition characterized by elevated blood pressure due to reduced blood flow to the kidneys, resulting in kidney ischemia. The most common cause is atherosclerosis of the renal arteries, though other contributing factors can include fibromuscular dysplasia, renal artery infarction or dissection, and vasculitis. The diagnosis of renal artery stenosis typically involves imaging techniques such as duplex ultrasonography, CTA, or MRA. A stenosis of at least 70% of the renal artery is generally required for the lesion to be considered a significant contributor to hypertension. Atherosclerotic renovascular disease is regarded as equivalent to coronary artery disease, and its management focuses on controlling blood pressure, lipids, glucose levels, along with antiplatelet therapy like aspirin or clopidogrel. Treatment for resistant hypertension generally involves a combination of medications from different classes, such as renin-angiotensin agents, including ACE inhibitors, ARBs, or direct renin inhibitors, calcium channel blockers, diuretics, and possibly beta blockers. Clinical studies have demonstrated that adding a low-dose aldosterone receptor antagonist like spironolactone or eplerenone can be particularly effective in treating resistant hypertension. If additional blood pressure control is required, or if the patient cannot tolerate the primary treatment options, other medications to consider includes vasodilators such as hydralazine or minoxidil, alpha blockers such as doxazine or prazosin, or central sympathetic agonists such as clonidine. Now let's discuss some rapid fire concepts. Automated blood pressure is better than manual. Ambulatory blood pressure monitoring is the gold standard in assessing blood pressure outside the clinical setting, especially when we're evaluating for white coat hypertension and mask hypertension. And of course, consider an upper arm cuff instead of considering wrist cuff when monitoring blood pressure. Know the definition of hypertension, which is a blood pressure more than or equal to 130 or over 80, and should be diagnosed based on average of 2 or more elevated systolic and or diastolic readings taken on at least 2 separate occasions. Understand the concept of white coat hypertension and mask hypertension. White coat hypertension occurs when blood pressure readings are high in the clinic but normal at home, and treatment is often not necessary. Mask hypertension occurs when the blood pressure readings are normal in the clinic but high at home, and consider treatment in this population. Make sure that you can easily identify a vignette that's considered resistant hypertension. Resistant hypertension is defined as blood pressure that remains above target goal despite being on 3 blood pressure agents from 3 different classes, one of which must be a diuretic, or if the patient's blood pressure is controlled but is on 4 or more medications. If a clinical vignette indicates resistant hypertension, it is important to assess for secondary causes of hypertension such as OSA, CKD, primary aldosteronism, and renal vascular hypertension. Thank you. This concludes my talk on the high-yield key points of hypertension for your internal medicine exam and USMLE Step 2 exam. Good luck.